Hello. So we're just starting off a case here. So there's a 58-year-old gent who's got some AF and heart failure. So found out about 8 months ago. I think he tried some antiarrhythmics and cardioversions and things first, but he's made it here for ablation now. So he's come for a first AF ablation for persistent AF. So I suppose there's different ways and means of doing that. And I suppose you might have talked about a few options already today and otherwise. But I suppose for this case, we've been asked to show off the new EnSight system. So EnSight X with the HD grid and omnipolar mapping, and in particular a Tactiflex. So Abbott's newest ablation catheter. So I suppose how that differs to their previous ablation catheters, so the Tacticath that many of you will know. I suppose it's a slightly different format, the tip of the catheter. So it's been laser etched to give it little grooves through which all the irrigation comes through. It's irrigated at slightly lower rates, but over a sort of wider area. And it's slightly flexible. So if you push it against a tissue, it will bend slightly against that. It will open up those pores and it will irrigate preferentially towards the areas that are being ablated, so the tissues that you're in contact with. So that's the format of the ablation catheter, but probably or possibly more noticeable even as a user is there's some on-screen changes. You can probably just about see that on screen if you've got the EnSight on screen now. Really, I'm still building the geometry. You can probably see on the ablation catheter on the left screen, on the bottom left, the ablation catheter's got an arrow at the end showing you where it's in contact. And you can either show that up as the arrow or the cone that was available on the last version, the Tacticath. It's got colors around it. So it's got red and blue. I suppose this first iteration's bidirectional. So the blue is towards the big curve. It's the way everyone remembers. And that shows up on screen as both the blue end of the catheter and on both the grid and the Tacticath. So the Tactiflex, it shows up there's small red lines and blue lines pointing out which show which way it's going to deflect towards. With either the D or F deflection. Should I go AP on the left? Yeah, so I suppose it's very nice to use internally because you can see where your catheter is going to move the whole time. And I think it's particularly useful for CARTO users. So if people are very hooked on the arrow, in addition to having contact force, and the red and blue to show you where you're going to deflect towards, as I used to be. I think it makes it an awful lot easier, particularly if people are used to CARTO and trying out EnSight. Possibly one other thing about the ablation catheter is because it's got this etched surface, and because it bends slightly when in contact, it seems to grip the tissues very slightly. There's just the slightest bit of friction. It is noticeable when using it, or if you go and play with it at a conference in one of the booths, you'll see that it grips the tissue a little bit. So I think you do actually flick less. It is very slightly easier for maintaining a sort of a static position. Okay, so I suppose back to where I'm up to with the case. So I'm building my geometry. I've got my ablation catheter through an Agilis, and I've got my grid through an SL1, and I've got my ablation catheter in the coronary sinus. So I suppose in the case, we've put our sheaths in. I suppose all ultrasound guided nowadays. We've had the TOE probe down for the transeptals, and I've passed the map catheter alongside the access for the grid. And I suppose now I'm just trying to make a beautiful map for us. So you could argue that I'm over baking this. first procedures for persistent AF, often still just pulmonary vein isolation. So I suppose the core part of the procedure is going to be pulmonary vein isolation, and everything else will be sort of optional extras or bonus country, perhaps. I think I was asked to put forward some multiple choice questions, which I did a bit late, but I suppose I'd suggested maybe one obvious discussion point is talking about lesion sets for persistent AF, if you guys haven't done it to death already today. I think the grid and omnipolar mapping particularly nice, though, because it gives you a very beautiful voltage map. So it gives you some really clear detail. I accept this is mapping in atrial fibrillation, so it could be slightly different in sinus. And I suppose if you were going to do a true scar-based substrate modification, you could make a case for doing it in sinus rhythm. I suppose that's probably where the evidence is so far. Although I think you could make a case for doing it in AF. Even with omnipolar mapping, if you look at bipolar maps in AF, there's an awful lot of low voltage, which might be partly due to wavefront directions and all fake news. But I think you still see quite a lot of low voltage with omnipolar mapping, even compared to sinus. And I think there are genuinely some areas that have low voltage over them and can appear as scar in AF. So not just an artifact of measurement. Although I'm sure you've all heard there's quite a big difference between what you see with omnipolar mapping versus what you see with conventional bipolar. Okay. So I'm just finishing this geometry, and then we can start with our ablation.
So, hi, Ross. This is again Julian.
Hi.
I think Arizona is still working on the tone. Just to
sure.
start off,
to
jump into the discussion. It is
a
beautiful map. First of all, congratulations on this. It is striking again. Also looking at the recently published ERASE AF data, persistent AFib patients, and 2/3 of those patients, even in sinus rhythm, showing, let's say, defined healthy voltages. So I would be interested, what is the experience from our panel looking onto voltages in the specific cohort of persistent AF patients? Would you have expected that type of map, or what would typically be the case in Spain, for instance?
The lesion set we use, and can you hear me?
Now it works perfectly.
Yeah, I can hear you.
The lesion set we do for the first AF ablation procedure in patients with persistent AF is a wide circle ablation. So in the first procedure, we don't try to map very precisely looking for the low voltage region. Maybe after knowing the results of the ERASE, in some cases we could change and try to select some patients for doing PVI plus, but until now, what we have done for the first ablation in persistent AF is only to do pulmonary vein isolation with wide circles. So we usually don't target the substrate after the entrance of the pulmonary veins.
Could you move that around for us?
So Julian, your question was my experience on voltage maps for
also
AF ablation?
And what? Maybe Marseille is a little different to Barcelona.
So I think voltage is a very important information in AF ablation. It's a very important information, but we know that voltage maps in AFib are different than maps in sinus rhythm. And also, when you pace at different frequencies and you pace in different sites, your voltage maps change a lot. So that's why I think this information is very important, but I would be very cautious to use it for an ablation strategy today. And in Marseille, yes, for such patients, we are doing what we call a patient-tailored approach. So
Should
very
we stop
close
collecting
to,
there, maybe? Should I dial up 45?
Yeah, so we are doing a patient-tailored approach, very close to this kind of approach, encircling areas of substrate. But I look forward new data on voltage to see what's happening in the future.
Yeah, thank you very much. And before we go back to London, maybe Isabelle, your view on the voltage.
So should I go with the standard?
I do agree with my two co-panelists that voltage in atrial fibrillation is an information that is not quite always, I wouldn't say reliable, but reproducible, and can be quite variable from patient to patient. So I don't tend to use voltage very much to guide my strategy for, especially for a first persistent AFib ablation. I tried to enroll these patients in some projects we have to assess different strategies for our persistent AFib ablation. For example, we have two. In fact, one that looks at like isolation of extra PV foci, isolation of the posterior wall, and also ablation on specific areas of low voltages area. But it is done within research protocols, which I think is what will give us answers in the future.
Wonderful, thank you very much. So let's move back to London, and Ross, tell us what you did.
Yeah, no, I definitely agree with all those comments, and that sounds very clever. So I've finished doing my geometry, and I've sort of done a sort of voltage map at the same time. I've started doing my whackers now. So to guide ablation with a TactiFlex, the company so far are recommending using time rather than LSI. I think it's not really been validated with anything else yet. So they have, depending on the power that you want to use, they will suggest different durations for burns. So at the moment, they're suggesting 10 seconds for 50 watts or 20 seconds for 40 watts. But I think obviously some people might use powers in between those. It might differ depending on if you're on the posterior wall or the anterior wall. And so I think there's still some work to be done about sort of dosing, really. Arguably 40 seconds for 20 watts might be considered quite a lot in most places, especially on the posterior wall. So I suppose based partly on their data and partly on just experience from other catheters and sort of SFs and high powers using other systems and things, I've been using 45 watts. I've been doing about 12 seconds posterior and about 15 seconds anterior. That seems to be working pretty well so far. Seem to be getting first pass isolation much of the time. We'll soon see if that's true today.
And Ross, this is
I think whether to use voltage after that's very unclear. So yeah, you go on.
We're really excited that we finally logged in here from Arizona and joining this global session. And thank you, Antonio, Isabelle, and Julian, for your patience, and all of our viewers. Ross, congrats on a great start here as you go. One question I just had for you as I'm jumping in here. Yeah. What are you doing to delineate the course of the esophagus currently as you're ablating on the wide antral region as you're starting on the left side?
Yeah, I suppose that's an excellent question, because we're not using anything. Esophageal temperature monitoring basically hasn't taken off at all in the UK and is not terribly popular in Europe, arguably. So I suppose we would not use anything. And I know
any comments,
many around the world.
And I think one of the I think this is great to show some of the global practice variations. Yeah. Antonio, Isabelle, and Julian, would you just like to comment about what's happening in Marseille, Barcelona, and Quebec?
We do the same in Quebec. We don't necessarily monitor the esophageal temperature. We sometimes delineate the esophageal position with ice just to see where it is, try to avoid ablating too much over it. But there is no physical means of either temperature monitoring or location, except for sometimes when we use ice that we locate it.
Julian?
However,
yes,
we tend to be very careful with the duration and the power we use on the posterior wall. That's mainly how we protect from fistula, more than looking at the esophagus.
Makes sense. In Marseille, we are monitoring the temperature with a probe, sensitherm. We also locate the esophagus using the TOE probe. On the Insightx or on the Carto, and of course we are very cautious on the time and the duration of the application on the posterior wall.
Let's give another 3,000.
We are. Excuse me.
And Antonio.
Can you hear me?
Antonio, you want to comment on the esophageal protective strategies in Barcelona?
Yeah, what we do, so our ablations are very based on the anatomy and in the information we obtain from CT scan. So when we are doing applications at the posterior wall, independently of the batch and time we apply, which is depending on the left atrial wall thickness, with respect to the esophagus, what we use is the distance from any point to the esophagus. This distance is projected in the posterior atrial wall like an isodistance map. So these isodistance maps give us information in addition to the temperature proof we use in the esophagus. And we try to modify, especially in persistent AEF ablation, to modify the delivery of the radiofrequency lesions depending on the distance to the esophagus. When the distance from the posterior atrial wall to the esophagus is less than 1 millimeter, we try to apply not more than 300 ablation index at this point.
I think this is fascinating for our viewers because part of watching this global EP showcase is looking at the global practice variations. You've got people using esophageal deviation, right, circa probes and multi-electrode probes, that's not even putting a probe and monitoring at all, which is what we're seeing here. And none of us know what the right answer is. And we all know that, you know, there's been no data to suggest that probes really prevent AE fistula. Matter of fact, the majority of the unfortunate cases have probes in them. So temperature rises are not ubiquitous whenever we do have a complication. Ross, keep taking us through this. And the other comment I was going to say when we had the voltage discussion, it is a function of how long your catheter is in one position. I think there was a great paper from Jeff Lee that was showing that if you're there for 3 seconds, 5 seconds, you'll probably catch some peak voltage, which actually starts normalizing. So sometimes we observe that as you sit there longer, the voltage starts becoming more and more normal because you're increasing the chances of finding a larger amplitude signal. So a lot of it's the frequency of how long you're at each position. Ross, please take it away.
Yeah,
as you're making the tour down the left-sided veins here.
Yeah, we're working our way up the ridge for the anterior veins now. Yeah, so I suppose I've been using 12 seconds posteriorly and 15 anteriorly at 45 watts. I think we're cautious about dosing as well, although I tend to think of it as cautious about dosing rather than cautious about powers necessarily. There's been a bit of data about using sort of lower powers for longer lesions or higher powers for shorter lesions, and it doesn't seem to cause more in the way of esophageal temperature alerts. I suppose there's even a rationale for why it might not, why you might be better off doing sort of shorter, higher power burns. We've had a little experience. I think you've got a case sometime in your itinerary using the Q dot, the high power short duration with Carto, so the 90 watts for 3 or 4 seconds posteriorly. I'm hearing that so far that's still going well and no sort of safety concerns as yet. Okay, so I'm working up the anterior ridge now. I suppose trying to go relatively wide. Although for the anterior ridge, I always try to go either end on or just on the venous side of the ridge. I always find if you're properly into the properly working your way up the ridge, then it seems impossible to isolate, and you only end up coming up on the inside anyway. So for first procedures, I'm hearing that everyone's going for pulmonary vein isolation at the moment. I suppose my understanding is the limited data that's coming through as to what else one might do. If I were going to pick things from the trials, I suppose I'd be thinking about ligament of Marshall, so ethanol injections. And I suppose there's that limited data now, isn't there, for low voltage zone modification, however you want to do that. I suppose we've heard some views on ablation of low voltage zones. Is anyone doing ligament of Marshall ablation routinely for first ablations?
Well, when you really look at the totality of the PVI plus question, there's really been two that have been shown in RCTs, and that's Converge with taking care of the vestibule and the posterior wall, right, surgically with the convergent procedure, and then there's obviously vein of Marshall. But the one thing they have in common is they address the substrate transmurally. The low voltage does appear that it's mixed data, and obviously Erase AF came out in New England Journal of Medicine evidence, but we have to remember that DCAF2 has not shown compelling, but there's obviously different ways to address low voltage. Antonio, Isabel, and Julian, you want to comment on whether that's a part of any of your local practices currently with the low voltage ablation?
We don't do that, especially in first AF ablation procedures. And with respect to voltage and the possibility to treat low voltage zones and the relationship with the left atrial wall thickness, we have seen that there is no relationship between the voltage. You can map in a given region and the thickness of the left atrial wall at this point. With respect to the use of this low voltage region ablation, we have performed in some cases in a redo procedure, but we don't do that routinely for first AF ablations. Yeah.
Isabel or Julian, is there anyone in your group or your local practices that's adopting low voltage? I think you'd already commented a little bit, Isabel, that it's more done under experimental protocols.
Yeah, we currently have the Coast AF protocol here in Canada, which is a multi-center study where we randomize.
So I can just see if we've missed anywhere.
So we randomize people to either WACA, like just pulmonary vein isolation, or extra low voltage ablation, and depending on the area of low voltage, it'll depend what strategy we will use to ablate that area. So we're currently enrolling patients in that study, and that's those patients in whom voltage will be considered as a strategy for a persistent AF ablation. So we'll have to see the results of the study to conclude.
And in Marseille, we don't use low voltage map. We are doing a tailored approach and electrogram-based ablation. So we use, of course, the voltage, but we combine the voltage to the local activation and the fractionation, like it's done by Amir Jadidi and Thomas Arends, this kind of approach. So electrogram-based ablation, including voltage, of course, but not following only voltage. And I was very interested in the voltage guided ablation, but the stable SR trial, it was negative a few years ago in comparison to the stepwise approach. For me, was very important. So I'm very interested in the ARAF trial. I think there are some limitations in this study also. We have to analyze the fact that in patients without any low voltage areas, that was 70% of the cases in the PVI plus group. So these patients only underwent PVI, and the difference between the two groups was at 13% in theoretically comparable groups. So I think
it was already significant with PVI versus PVI.
Yeah, of course, it was not significant because there was not enough patients, of course. Yeah, of course, that's true. But that's important to notice. And so I think that's very interesting. I think it's work in progress. I think it's going in the good direction because I believe in the tailored approach to adapt our strategies to each patient. So I think that's a good thing. But I do believe that voltage should be included in other parameters, other features to analyze the substrate.
It's also worth commenting that the way that low voltage ablation is done in all these trials is different. You know, when you look at a race, they took the low voltage to guide a linear strategy. So if there's low voltage on the roof, then they would complete a roof line or really to extend something. Whereas in decaf 2, there wasn't always a completion of line. So that's important for the viewers when they start analyzing this data, to take a look at the differences of even how low voltage ablation is working. And we all understand in the ventricular tachycardia world, homogenization is not homogenization. It may look different for every single scar at every different center. But mechanistically, I still have to push back and say that we haven't proven that atrial fibrillation originates or is perpetuated or maintained within fibrosis or scar. And just because you see slow conduction doesn't mean it's what's driving anything. It's hard to imagine that AFib is like ventricular tachycardia, and if we ablate all the scar, AFib will go away.
Exactly.
And that's always been something that we need to understand much more as a group. And with VFib, if you take a look at something that we understand a little bit better, it's all trigger-based, and it's very limited data to suggest that substrate modification decreases the propensity for VFib. So I think this is really interesting, but it's good that it highlights that there's more mechanistic work to be done. Ross, back to you to update us how you're doing on that lap up against your ridge.
So we've finished the left and we're working down the right now. Yeah, so we've got a PV in the right upper, so hopefully get to see when this one isolates. I suppose I was thinking during your talk just then, possibly one of our mistakes in all this is we're looking for one cause in everybody. And I suppose we'd probably all agree at the same time that it's a multifactorial thing, wouldn't we? There's lots of different things that can set it off, lots of different patterns that we see. Could be more than one thing at play. So just because scar works for one person doesn't necessarily mean it's a one size fits all for everybody. Yeah, I suppose time will tell.
And then Ross, we're looking here at your contact, and it's oscillating between 2 and 20, which is obviously can change with respirations, etc. Are the patients currently spontaneously breathing or intubated?
It's intubated and ventilated, so it's all under general anesthetic. I suppose I'm aiming for about 10. I suppose I'm usually accepting if it's above 5. If it's below 5, then I'll be upset and be thinking about repeating that lesion. There's also a facility on this actually where you can have an impact of your contact force on what you're looking at. So for example, I've got it showing up here with time for the ablation lesions, just because that's what we're using till something else is shown to be better. But you can also make your lesions either bigger or smaller. You're being shown on screen there. So for example, if your average force is low or below 5 or whatever you set it to, then it will show up as a smaller lesion. So would you just show them on the left-hand whacker? I'm sure I have 1 or 2 that were so-so. I think on the anterior, quite high up.
If some of this
can you see that one on the top left? There you go. Yeah. So that one would have been particularly low force and hence has appeared rather tiny. So it helps you keep an eye on that. And I suppose the other thing you have an option to do, and what I do is if I think it's been so-so in terms of contact force, or if I think it's been more mobile than I would have liked, then I overshoot slightly on the time, really. I suppose another thing that's very nice is at the roof, if you've got the luxury of general anesthetic, particularly for the right roof, I'll often ask for a brief breath hold. My anesthetic colleagues will normally turn off the gas for a minute.
And this is where a lot of people are using
line or struggling at the roof.
Using jet ventilation or lower tidal volume, maybe 200, 250 at 40 at a higher frequency to try to emulate jet.
We've not been doing that, but it sounds fantastic. There's even small RCTs using that, isn't there? Yeah.
So we recently just transitioned to lower tidal volumes and higher frequency.
Have you? What settings do you use out of interest?
Tidal volumes have gone to 250 at maybe 40 frequency, and then check blood gases and make sure they're adequately ventilating and oxygenating. Any comments on any ventilator strategies, Antonio? They're usually fine because you can still look at an end tidal CO2. So it's just as long as they're satting fine and the end tidal is okay. You know, you could try something at 250 and then at fast frequency. Antonio, Isabel, and Julian, you want to comment on that?
Yeah. Yes, we use we don't use jet ventilation because we do ventilation with standard ventilation systems. So what we use is high rate, low volume, and typically the rate is we consider is high rate between 40 and 60. Very frequently we have between 50 and 60, and with respect to the volume, tidal volume, it is very frequent to have around 200, maybe 180 in some cases, 200, 250, but this is approximately the data we have. And there is a high benefit with this way of ventilation because we perfectly feel the catheter stability. In fact, since we are using this kind of ventilation, we do not use any deflectable sheet into the left atrium, and we maintain the sheet in the right atrium, taking care also to don't increase the possibility to have any thrombus formation into the left atrium. So it increases a lot the stability, and also is good to have a very good fusion between the electroanatomical map we obtain and the CT scan we use to guide ablation.
While we get the other comments, Ross, if you're open to it and we want to do a 200 at 40 and have your anesthesiologist change it, it might be fun to show in a live case if there's any difference. If you're committed to that, then that's okay. We understand there's different practice variations.
I'll get making my anesthetist now. Gianpaolo, they're saying in their center they've had very good experience with very low tidal volumes. They said, would we like to try something different and see if it's noticeable for those on screen? They're saying they normally try about a respiratory rate of about 40 and a tidal volume of about 250. Be okay to try that for a short period? So we're going to...
Isabel and Julian, you want to talk about how you modulate respiratory stability to improve?
For my part, it's going to be quite short, honestly, because I tend to make my life a little bit hard since I do AFib ablation under sedation, so they're not intubated, and I don't control the ventilation. I try to avoid having deep breaths and make sure that they're not obstructive, so that you avoid the very deep breaths. But I don't control the whole ventilation.
That's possibly why we haven't evolved on that front too, really. A lot of our stuff is done under local anesthetic and sedation. I think of our 5 EP and devices labs, we usually only have 1 general anesthetic list. So vast majority of our cases are done under local anesthetic and sedation. So this is a treat for me today, having everything still and no one misbehaving on me.
Julian, any comments on respiratory stability, stabilization?
Yeah, no, very quickly. Very quickly, it's the same answer than Antonio. We're not using jet ventilation, but short volume, high frequency, and we observe a good stability. And I don't use steerable sheets, so I can use my SL0 sheet, and I'm happy like this.
Well, we can see if Dr. Hunter enjoys 250 at 40 at all. If there's any
I suppose he was actually moving very little beforehand, but yeah, I mean, this is very, very still.
I know we're anterior now.
Yeah, we're coming up to the roof, so I suppose this is where I should notice all the difference. I'll tell you something else I didn't really mention earlier is for whatever reason, the signals during ablation with the Tactiflex seem to be barely affected by ablation. So if I come on here and you watch during ablation, on a great deal of signal up here as it is in my full contact force, but you'll see there's barely any ablation artifact. Are you able to see that on screen?
We do. You're saying there is less.
Quite impressive that there's almost nothing that comes up. Yeah, I suppose the the other systems that I'm used to and the other catheters that I've used before with this system have, I've always experienced a little bit of noise with ablation, but I suppose it's quite remarkable there's almost none. Sorry, just working out the end of, yeah, I mean, it's very nice. We're up at the roof now, and barely any movement there. I'm sure you guys would agree. I suppose the roof is possibly the most precarious point on your right whacker, at least in terms of sort of stability and impact of respiration and things. But yeah, it's very nice. Oh, you can see the PV's just gone there. Would you F7 and drag back on Bard? So the right veins are just isolated there as well. You can claim that as a victory for respiration. Yeah, I mean, that's we've been lucky, but I suppose we've had first pass isolation with both vein pairs again. Yeah, I suppose my MO with ablation for persistent AF, particularly in someone like this with quite a big atrium, bit of LV impairment and that sort of thing, would be to do relatively wide whackers. Not super wide because I don't want to spend all day doing them. And I suppose if my whackers are very close in the middle, sometimes I think it would be rude not to do a roof line. But yeah, often I would stop there. I suppose I do often give a little bit of fleckenide during the procedure, and I've given this gent a tickle of fleckenide even with the LV impairment. I figure he's being monitored and he's got a narrow QRS. And I suppose if he happens to organize up into an atrial tachycardia, maybe we'll deal with that at the same sitting.
Oh, that's interesting. When do you give
yes,
fleckenide and how much
you could argue that
do you
as
give?
I would just trickle some in during the procedure. So in the UK, at least, it seems to come in a 15 ml vial, so 150 milligrams, that is. And I'd normally give a bolus of 50, wait a while, another bolus of 50. And then if they're not on any other antiarrhythmics, I might trickle in the last 50 a bit slower. So this gent who's got some LV impairment, we've given 100 milligrams in increment just to see if he organizes up into a tachycardia. I completely accept that. You know, you could say that that's iatrogenic. You know, if I were doing cryo and he went into an atrial tachycardia, I wouldn't necessarily map it. I would cardiovert at the end, and they seem to do just fine. But I suppose it seems nice if they develop an ATAC in the procedure to be able to ablate it at the same sitting. So I don't think there's any massive gaps here at the roof, but I'd usually be slightly generous at the roof and maybe put a little bit in just inside the os of the vein at the roof, just because I know it's well, firstly, a bit of a culprit for unstable lesions, but also a bit of a culprit for reconnection, I find. Both here and, of course, the carina back and front. But the right roof especially, really.
How often do you find that you need to ablate in the carina on your wide anterior differential lesions?
Yeah, I suppose I wouldn't often ablate truly across the carina, but I would not uncommonly, so if you've done a sort of a hula hoop on each side, I would often dot one just inside, just above and just below, where I think the middle would be. So maybe I've fallen off there anyway. I'll come and try and point to it with the ablation catheter in a second. So should I go right lateral on the right? Yeah, so I haven't really done it very much, but if we, so I suppose common sites I find for reconnection are just inside there, just inside the right lower below the carina, and then just inside the right upper, just above the carina. So if I'm struggling to isolate or if the lesions have been unsteady or anything else, often that's the first thing I'd do. Dot a couple there back and front, and maybe a little at the roof as well. The roof on the right, and maybe the roof bordering on the appendage ridge on the left. Okay, so we've completed PVI now, really. I suppose various other things you could do. I suppose if the veins were very close together and the posterior wall looked direct, accepting that it's in AF, I might still do a roof line and may or may not box the posterior wall. But I mean, I wonder looking at this, even in AF, the atrium doesn't look that unhealthy. It's quite a long way between the veins. I wonder if I'd be making a rod for our back, sort of high chances of that unblocking in future and coming back with tachycardias and so forth. So I'd be inclined to stop here, really. recheck my veins.
Antonio, Isabel, our panel, are we comfortable stopping
Any
here?
other takers? Yeah.
And what else do we want to see?
Now, I would cardiovert the patient,
what our panel wants to see.
Shake all the veins, and probably stop the procedure. I will not do anything more for the moment in this first ablation case.
Do you do waiting periods?
Great, Dr.
Or
Bruzzo's done.
Or isoprenoline or anything like that?
I do agree with Antonio. That's what I would do too. And if I may add, in Canada, most of centers have pretty long waiting lists. So what I tend to do, and what a lot of people tend to do, is keep them in sinus rhythm prior to bringing them to the lab.
Should we cardiovert?
It may take a few months to bring them to the lab.
Ross, can you hold?
So we tend to keep them
in
sinus rhythm sometimes under amiodarone, so that the first intervention we do is easier than to do only PVI, since most of the patients who come in the lab are in sinus rhythm and not in atrial fibrillation. Now, I think we could argue doing adenosine to check if the veins have dormant conduction. I don't do it every time, but I do it if I seem to have a vein that is quite active or has reconnected a few times. I do it more with RF than with cryo. I would wait maybe 10 minutes before rechecking the veins, and that's I wouldn't do extra lesion sets aside what Ross already did.
Is this PVI alone okay in Marseille?
For this kind of patient with persistent AF, especially patients who arrive in AFib, we don't do PVI alone. So we are performing a substrate mapping, a biatrial substrate mapping, and ablate these extra PV regions in addition to PVI, and try to convert to sinus rhythm. But I think the biggest question here for all of us is in which persistent AF PVI is sufficient? And I think for now we don't know exactly how to answer this question. So that's the biggest question. So maybe here PVI could work, I don't know. But if it's not sufficient, the problem is that when you do for complex persistent AF, sometimes you start to do several procedures to be effective. And sometimes only a PVI only procedures can be a procedure that will not be effective. And after you will start sometimes two procedures. So for the patients and the cardiologists, sometimes it's complicated to understand that first PVI was not effective, and now we are starting to do a substrate-based ablation. So that's why we are starting by doing this kind of substrate-based ablation with extra PV ablation. But sometimes we over-treat patients, I believe. But sometimes, of course, PVI under-treat patients. So we don't know how to answer this question exactly.
Thank you. And Ross, have you guys held off on the cardioversion still? I was wondering if I could ask if for
we haven't done yet.
Yeah, for a quick remap in AFib to just look at the veins there. And then I was curious to see if you sit longer at some of those regions in the vestibule in the lower areas, do the voltages actually start normalizing? And we could look at that, the one before and after, because we haven't modified the posterior regions or the vestibule.
Okay, so do you mean find an area in AF with low voltage and sit on it for a while?
And just sit there, exactly, and just kind of redo that region.
Okay.
Just to highlight if there's variability or if things normalize.
Yeah.
Some people really believe that voltage is more accurate in AFib.
Yeah, I mean, I don't have a lot to back it up. There is a little bit of data that suggests it might correlate with late GAD on MRI, at least as well as voltage in sinus rhythm. And even if there's nothing there in sinus in terms of low voltage, I still think it might be mechanistically important in AF. I mean, I haven't got much to back it up, but I do wonder that if we'll end up ablating it in AF rather than in sinus rhythm, if that might be
Are you able to get to that area right adjacent to the RIPV, just slightly inferior to the RIPV where there was notable low voltage? on the first map.
RIP, yep. Okay.
And really ensure contact there and take a look.
Yeah. My contact there is not great. I'll tell you what sometimes works quite well there is to try and invert it and then spin it and straighten it against there.
Yeah, that's a great move.
So a bit more low symptom there, isn't it? Okay, there you go. Sort of coming up to, still not quite, is it? Can I go back to that PA view again? We're just trying to get to that low posterior. Yeah, great. Yeah, still not sure we're quite on it. Do you want to move that right hand view around? See if we're
So as he's doing that, we've got about 2 minutes left in the case. Any final comments before we have Dr. Hunter summarize this? Because I think the whole panel is in consensus that we're good with this, except for in Marseille, they might do a little bit more stepwise. And I know that's a trend as well as the Bordeaux group, that they went away from stepwise. And now they're going back to
could
stepwise.
Turn it back now would be fine.
Highlights the variation. Any final comments, Antonio, Isabel?
In danger of falling out, but I think that's the right spot there, isn't it?
One final comment, maybe from our point of view, maybe it is more important to look for other things than more important than low voltage. There are zones in the left atrium that always have low voltage. For instance, in the anterior wall, you have the unprotected area, which is behind the aortic roof, that always has low voltage. Maybe also close to the left inferior pulmonary vein, you always can find low voltage because there is the presence of the descending aorta there, which is touching the posterior wall. So it is, for me, we think, or we have the art of the opinion that maybe looking for other things like slow conduction. We have a protocol now running, looking for that during sinus rhythm, and introducing a couple or three extra stimulus into the left atrium. And sometimes we find these kind of features with extra stimulus. We find some zones of the left atrium showing low conduction, which is present in zones with low voltage and with normal voltage. And maybe this could be a good target in the future. We will look for that and try to see if there is any benefit, but we don't rely too much in low voltage areas. So the case of today is a very nice case, and I think could be enough for a first case in persistent AF ablation. So this is my final comment.
Isabel?
Yeah, I do agree. What I would add is I'm sometimes very surprised by the voltage maps of my patients, because sometimes they have quite long-standing persistent and there's very little low voltage, whereas sometimes it's a paroxysmal atrial fibrillation and common in an atrium, which is almost devastated, like very, very low voltage everywhere. And I'm not quite sure what exactly brings. I think it's not only the persistence or the duration of atrial fibrillation, but there are other features that do influence the voltage, and exactly what we need to do with these cases, I'm not quite sure yet.
And Julian?
And I would say that I totally agree with what you just said, both of you, and what you said also before about the fact that I think low voltage is a very interesting feature to analyze, but it's not sufficient, in my opinion. And I think it's difficult to translate what we know from ischemic VT and SCAR, and a very simplistic mechanism for reentry in AFib. And I think it's not the same disease. I think low voltage and SCAR, of course, play an important role. That's very important. But I do believe that drivers, slow conductions, all these things we have to understand to go further in the mechanistic understanding and mechanistic ablation for persistent AFib. And so, but that's a very nice case. So congrats to Dr. Hunter on this. And it looks like the TactiFlex catheter seems very good. Do a good ablation and allow to do a high power, short duration. So thank you very much.
Yeah, I agree. I think even though we know that termination of AF doesn't appear to portend a more favorable prognosis, I'd have to insist that the termination of AFib is mechanistically valuable, and for us to understand why that happens, how it happens, and when it happens would be useful for us to gain a better understanding of AFib. Dr. Hunter, your final comments, and we really want to thank your team at St. Bart's, your generosity, your courage to highlight this case. You did a beautiful job with this wide antral circumferential ablation with 4-vein isolation in this persistent AFib. We'll turn it to you for some final thoughts.
Yeah, I suppose really we've been demonstrating what's the sort of widespread gold standard for AF, really, aren't we? I suppose wide area circumferential ablation. It's a shame after decades we don't have more to add on top of that in terms of definite evidence about one thing or another. But we've had some great debate tonight about the different things that we could or should be doing. Yeah, the EnSite system with the grid and the TactiFlex working very nicely as a combination. So I hope I've done that justice. But yeah, no, we've been very lucky tonight. It's been a great case. So thanks all for your input.
Thank you very much. And we played around with the respirations and ventilators.
We did.
Maybe we even showed that there's more stability. We talked about the variation in esophageal protection strategies from nothing to deviating it, in the US, which is very popular. It's amazing how much variation there is in this one procedure that we all do so commonly. So thank you very much to our panel. Thank you so much to Ross Hunter and his whole team at Bart's. There's still plenty more to come on Rio 2022. Join us for the next session. Thank you.